Kính thưa quý vị đại biểu, ngay bây giờ hội thảo vệ tinh phiên 2B sẽ bắt đầu từ 11 giờ đến 12 giờ 30 với chủ đề
Ladies and gentlemen, the Satellite Symposium on RPL and Miscarriage, Evidence-Based Medicine, with the two lectures. The first lecture is RPL, what should we do for prevention, would be delivered by Professor Giancarlo Di Renzo, Honorary Secretary General of FIGO from Perugia University, Italy. And the second topic, threatened miscarriage, evidence-based medicine for live birth rate, delivered by Professor Shilpa Nambiar Balakrishnan from Malaysia, together with simultaneous translation by Dr. NG. To begin the program, I would like to call upon Dr. Quang Thanh to handle the program.
Kính thưa quý vị đại biểu, chúng ta
Ladies and gentlemen, we are going to begin the Satellite Symposium, Prevention of Miscarriage and Recurrent Miscarriage. I'm sure that all of you agree with me that miscarriage and recurrent miscarriage are the most frequent complications during pregnancy, and it's difficult and challenging to handle, and especially in terms of prophylaxis and prevention. And recently, there is quite a lot of emerging clinical evidence of prophylaxis and prevention for people with miscarriage and recurrent miscarriage. We are going to listen to our two speakers, who are well-known speakers in the world, Professor Di Renzo and Professor Shilpa Nambiar are quite prolific experts, and with updated clinical evidence and clinical trial demonstrating the role of therapy, especially micronized progesterone intravaginally, The first speaker would be Professor Giancarlo Di Renzo, Honorary Secretary General of PHIGO from Perugia University, Italy. He is the very similar face and speaker with our meeting. Thank you. The podium is yours, sir.
Professor Tan, thank you very much for your invitation here. It's a big pleasure after 3 years to be back to your meeting and to refresh our friendship. We know each other since many years, and I'm always happy to be in Ho Chi Minh City and to visit also your big hospital. In this presentation, I will address some issue related to the news that we have in the possibility of prevention of threatened and recurrent abortion. As Professor Tang said, this is a very frequent problem, which 1 every 4 to 5 women experience in their reproductive life. So, even though it's frequent, it should not be under-evaluated because it has consequences. It has consequences for the subsequent pregnancy. It has consequences for the life of the women, especially from physical and psychological point of view. If we say that 1 every 4 or 5 women experience, this is not the true number, because the loss in pregnancy is much higher than the clinical evidence of an abortion. Especially in the period of pre-implantation or the early implantation, the rate of loss is at least 3 times higher than the clinical evident ones. The mechanism of pregnancy is not an easy one. Nature has made a lot of sophisticated mechanisms for the fecundability and for implantation in order to optimize the offspring. These, however, request a lot of loss. Therefore, we should know that what we are talking about mainly is only 10 to 15% of the overall problem of pregnancy loss at the beginning. These are very recent data which show that pregnancy loss around the clinically evident is around 15% in the statistic, very big epidemiological statistic with 1,000 million cases around the world. But if I want to understand the incidence of a first miscarriage, you can see here that is around 11%, second miscarriage is around 2%, third miscarriage is around 1% and so on. So the total around is 15. Of course, everybody knows there are 2 major risk factors. One is the age of the pregnant woman. Not so much if she's a teenager, but very much if she's over 40 years. The second is the number of miscarriages which a woman or a couple experience. Going from 1 to 2 to 3, you see here in a statistic that we published in American Journal, we may increase the risk by 3, by 4, by almost 10 times. And this is very important to understand, that we have to do something, otherwise the risk of abortion after one abortion is increasing. Now we know that beside the female age, also the male age has an importance, particularly when the man is over 40 as well. In the past, this was not too much considered. And of course, another important factor is related to the BMI. So if there is obesity and ethnicity, because Black women have a higher risk of abortion compared to the Caucasian or the Asian. Many factors in lifestyle are risk factor for early pregnancy loss, particularly smoking, caffeine. You know that in Vietnam you have a very good coffee, but not exceed 150 milligrams a day, comprising Coca-Cola, tea, and so on, because they have caffeine as well. The second is alcohol. I don't think that you drink too much alcohol, but for instance, in Europe, particularly in the United States, alcohol is abused also from women in reproductive age. Work pattern and stress at work is another important risk factor. And of course, among the history, the medical history of woman or a man, the previous abortion, the polycystic ovary system, the uterine anomalies and so on are all factors that we know. One important is also DNA damage in the sperm of the man. So spermatozoa with DNA damage increase the risk of abortion. One important factor nowadays, everybody is speaking about environment, climate, and so on, is also the environment and climate influence the pregnancy loss, particularly air pollution and pesticides. I have a slide that will show that this is not only the air pollution, but also the toxic chemical we may have in even the kitchenware in every house. Biphenyl are ubiquitous in plastic, you know, and the amount of biphenyl concentrated in the blood of a woman we use, you know, the plastic for putting the food and so on, is related consistently with the miscarriage and also with the normal fetus miscarriage. So not the miscarriage related to chromosomal disorder, but the miscarriage which can be prevented. This is a very old statistic which I did in my hospital because I had a very big miscarriage clinic. These are more or less 500 couples. And you can see that if we go from the second to the third abortion, what is changing is mainly that the pathology which can be discovered can be prevented. For instance, immunovascular pathology like antiphospholipid syndrome. However, nowadays, couples don't want to wait free abortion to start a workup. They already ask to do something after the first abortion because there is much more request and much more attention to the problem. However, we should know that the first abortion has a very high percentage of genetic anomalies in the embryo. In some cases, even 70% in this statistic, but go between 50 to 70%. And what is the consequences of this? The consequences of this is that many studies which have been done in the past were underestimating this problem, and they never show any effect of any intervention, because there is at least a 50% of aneuploid miscarriage you cannot do anything to prevent. But if we go over the numbers of 2 to 3 to 4, you see that euploid miscarriages start to be more frequent, and there are other reasons why there is a miscarriage, and these other reasons can be prevented. One of these reasons is thrombophilia, and the most important thrombophilia is for sure the antiphospholipid syndrome. However, many others have been studied in the last 20 years. Some have been related to any risk of abortion, some other not. So we have to be careful when we speak about thrombophilia, not to make a mix of everything. Factor V Leiden, prothrombin mutation. These are very important for abortion. But for instance, metatetrahydrofolate reductase, which is the one that needs only folic acid, doesn't need any other intervention. As I said, antiphospholipid syndrome is the most important single reason for recurrent pregnancy loss. However, we have to be sure about this syndrome, which is very different in the phenotypic form, can be lupus, can be nothing. And of course, you know, since already almost 20 years, that the efficient prevention is to combine low dose aspirin, 100-150 milligrams given in the evening, to low molecular weight heparin. These are for sure, and nowadays, the best treatment. Concerning endocrine factors, again, nowadays we have evidence that thyroid dysfunction, particularly even subclinical hypothyroidism and pregestational diabetes, are an increasing risk for abortion. Endometriosis as well, because endometriosis is linked many times to derangements of immunity in the woman, as well as I mentioned before, the BMI correlated to metabolic syndrome, polycystic ovary syndrome, and so on. And last but not least, luteal phase defect. This is very difficult to ascertain, but luteal phase defect is the defect of progesterone which needs support, and this has been very important to increase the rate of live birth pregnancy. Now, when a woman experiences even one miscarriage, what is the risk in a subsequent pregnancy? We sometimes say, oh, a miscarriage can happen, don't worry, go home, wait 2-3 months and then try to be pregnant again. Be careful. It's not so. The placental abruption or placenta previa are much more frequent after even one abortion. So we have to be very careful about that. And also, preterm birth, lower weight, stillbirth are related to the number of abortions, particularly for more than 2. Finally, as I said, don't forget the psychological consequences. If a woman experiences more than 2 abortions, the risk of suicide or major traumatic stress disorder is very much increased. Saying that, also there are implications for the health of this woman. Who experience abortion have more risk later in the age, particularly in postmenopausal period, to have cardiovascular disorders. With all these problems, I think that it is very imperative that now we study more in order to prevent this disease. I remind you that the first person to suggest a cure for abortion based on the hypothesis that it could depend from a luteal phase defect was Georgiana Seager-Jones, a distinguished gynecologist in Virginia, who already in 1949 suggested to give progesterone. But that time there was only intramuscular progesterone, very painful. The micronized progesterone was not yet introduced. Nowadays, we know much more about the role of micronized progesterone in pregnancy, which is, of course, identical to the progesterone produced by the corpus luteum. In this particular issue of clinical diagnosis of obstetric gynecology of the British Medical Journal, which I edited 1.5 years ago, you can download and now free. We summarize many of the aspects of which we know nowadays about progesterone and pregnancy. You can see that at least for the beginning of pregnancy, the progesterone is the key hormone for the changes in the endometrium to favor implantation and to modulate maternal immune response to accept the semi-allogenic transplant, which is an embryo. But there are many other features, like to be an antiprostaglandin drug, to be, counteracting the stress hormones like CRH and so on. So progesterone has a multi-phase activity, which are important. As multi-phase activity, there are also many ways to administer progesterone. And we have to be very careful because according to the way we administer progesterone, we may have different effect in the maternal body. For instance, if we give by oral route, because the micronized progesterone can be absorbed very well now by oral route, we have metabolites which are coming from the gastrointestinal tract and the liver enzyme, which possess activity with the GABA system, partly hypnotic, partly anxiolytic, give dizziness and so on. So this can be useful in some cases, but not useful in others. If we give by transdermal route, there is practically no absorption by systemic, and we have maybe optimal concentration, a very thin layer, like it happens for instance, for the breast tissue. Intramuscular course is very painful, even though we have a subcutaneous aqueous vehicle, it is still a little bit painful, and may give also supraphysiological blood levels, which sometimes may not be helpful for what we want to attain. And of course, the most popular in the last 20 years became the vaginal or rectal, but mainly vaginal route, in which we avoid the hepatic effect and we go directly to the receptors which are in the gynecological organs, so the uterus, ovaries, and so on. Now let's, after these premises, let's see what we can do now for miscarriage. The scenario of what we can do for prevention of miscarriage has changed completely in the last 5 years, thanks to these two big studies, which together put together almost 5,000 women, 4,150, 825, so 5,000, which are 3 times more than all the studies which have been published before. So these two studies really changed the scenario of our intervention. This study put together show that if we give appropriate dosage of progesterone, which is not just 1 capsule of 200 milligrams, but 800 at least milligram a day, so is a high amount we need, we can have prevention of miscarriage, either in those women we have a history of miscarriage, either in those women we have a threatened miscarriage, actually, but one history of previous pregnancy loss. So the guidelines of many societies around the world changes according to these two big studies. Particularly, we are in Europe, we have the European Society of Human Reproduction, which has endorsed the use of vaginal micronized progesterone for the prevention of preterm birth. If I go to the literature, you can see here in green are the good study, in red are study very questionable. So the very questionable study usually are for, intervention which are not being popular, like to give HCG or bed rest. What we do if a patient has threatened miscarriage and we put in bed rest? Nothing really. But the green are for the use of progesterone. And we made a meta-analysis just 2 years ago, published in American Journal, of all the studies which have been done in progesterone. Of course, the most important were the two big studies which I just mentioned. And you can see that here we have a statistically significant effect of progesterone toward. When to give a progesterone is very difficult to say because, of course, a natural cycle, the woman comes to the doctor when the test is positive. But in IVF, we can intervene as soon as possible. It has been demonstrated that we need to start within 20 to 48 hours from oocyte retrieval to avoid abortion, much better. This is a very recent meta-analysis. So the major international society endorsed the fact that if progesterone can be useful, should be started in luteal phase. We should try to do the same in natural cycle as well, but it's more difficult, of course. What about other substances which we call progestogens, which are similar to progesterone, bind the same receptor, but they have different effects. Many times there are only one or two effects compared to the many effects of progesterone. No proof that they work, okay? No changes compared to placebo on the number of miscarriage, no statistical difference for live birth. Moreover, the use of progesterone given even at high dosage at the beginning, very early beginning of pregnancy, has shown to have no safety concern, no problem for the safety. Why? You know that progestogens are under scrutiny because there is a major risk of, for instance, cardiac fetal malformation attributed to one of these compounds. And in fact, recent Cochrane say clearly that micronized progesterone increased live birth rate for history of miscarriage or early pregnancy bleeding, no difference in adverse events. What are the studies demonstrated? Nowadays, we have an obligation as professionals. If we have a patient with a treated miscarriage or with a recurrent miscarriage, if we don't give progesterone, we should know that there is almost 2 times more to have a stillbirth, to preterm birth, placenta abruption, abortion, in any case. So we don't do something good, okay? And you know that very recently, the NICE has endorsed the use of progesterone. NICE is the National Institute for Healthcare Excellence of the Royal College of Obstetrics and Ecology, and they produced these guidelines just last November, less than 1 year ago. As you can see here, the progesterone is being endorsed, but other preparation need research to be validated. So don't think that we use a 17-hydroxyprogesterone, the dihydrogesterone, and so on. These are the same. Even the NICE say they are not the same at all. And you know, these from this publication from the NICE, the BBC made a very nice program a few months ago, and they show that if we now prevent treated miscarriage in the woman with the progesterone, there will be 8,500 more babies born in the United Kingdom every year because of intervention of progesterone. 8,500 babies more per year. Okay? But I call you, we have to give a high dosage of progesterone. Now the question is, when to stop progesterone? 12 weeks, like the most of the studies say, 20 because placenta is at least formed, so progesterone help in the formation of placenta, or to continue up to 36 weeks, decreasing the dosage to 200 milligrams to prevent preterm births. That is a big question mark, but I give you some conclusion that may open some highlights for this. First, we know that treated miscarriage, recurrent miscarriage need supportive doctor. But supportive doctor doesn't mean that we have to give any therapy which is unsubstantiated. Then, of course, second trimester abortion is a very small issue, but more difficult because it is comparable to preterm birth. We'll talk later. We know that in some cases, for instance, for thrombophilia, the combination of aspirin and heparin is the best choice for prevention. But now the role of progesterone is increasingly accepted. And look at these two data. Treated miscarriage in first trimester increase the risk of preterm birth. And recurrent miscarriage increase the risk of preterm delivery before 34 weeks by 3 times. So this means that probably we have to think that those patients need also prevention of preterm birth because are high risk of preterm birth. This is something that is not yet demonstrated, but is something that we have to consider for the future. So I would like to conclude that this pregnancy loss, early pregnancy loss, is something frequent in the life of a woman in reproductive age. It's frustrating because apparently it looks like we cannot do too much. Of course, in many cases at the beginning, we cannot do too much because it's linked to aneuploidies of the embryo, so chromosomal abnormalities. Whatever we give, this pregnancy is lost. But nowadays we have some tools for prevention. And we have not to recommend unsubstantiated tests or therapies of dubious efficacy. Also, drugs which are similar to progesterone, but is not progesterone. With this, I thank you very much. Come on, thank you very much, Professor Tan, for the invitation.
Thank you very much, Dr. Professor Di Renzo. Quý vị đại biểu, chúng ta có thể đặt câu hỏi cho giáo sư.
Ladies and gentlemen, you can raise a question to the speaker. You can raise some questions right now, and during the Q&A, some further questions. While waiting, I have two questions for Professor Di Renzo.
Yes, I have two questions for you just now. Câu hỏi thứ nhất,
the first questions. You recommend that after oocyte retrieval, progesterone should be given early for prevention of recurrent miscarriage. In case that it is just a natural cycle, natural conception without IVF, so when can you administer progesterone? Because it is difficult to know the time of ovulations. That is the first question. The second question, should we measure progesterone in plasma before treatment? Two questions.
The two questions are very appropriate. First, as I mentioned, it is difficult to establish a natural cycle when start progesterone. But if a woman is regular in cycle, we can presumably start after the 16th day of menstrual cycle, progesterone, after usually the intercourse, which is supposed to be, looking to get pregnant. However, you have to wait the pregnancy test positive, and then you start progesterone right away. Second question, no need to dosage progesterone. Progesterone is a very difficult circadian rhythm to be consistent. In the morning, maybe 10, in the evenings 20, the subsequent morning 7, and the subsequent evening is 15. But of course, there are some studies, particularly IVF patients, which establish a threshold. More than 10 is good. But if you look at sensitivity, specificity is not so high. It's a confounding and making many anxiety if it's low, because even this low, pregnancy can go on. So it's better not to measure at all progesterone.
Thank you. Sau đây chúng ta sẽ tiếp tục với lại cái chuyên đề thứ hai, và chúng ta sẽ có thời gian tiếp tục.
And now let's continue with the second lecture. And after that, we are going to have a Q&A for both speakers. And now Professor Shilpa Nambiar talking about threatened miscarriage, evidence-based medicine for live birth rate. Professor Shilpa Nambiar is the head of international relations of ARCOG UK Malaysia. She is also a popular speaker at our conference.
Hello, is it working? Thank you very much for your invitation to your beautiful country and to this city of Ho Chi Minh. I'm very, very happy to be here. I'm going to be talking after the great Professor Giancarlo about threatened miscarriage. Why is it not working? Okay. Threatened miscarriage, how to improve the prospect of live birth. Now, there is going to be some overlap between my lecture and Professor Giancarlo's because it is very difficult to talk about threatened miscarriage just by itself. There is almost always someone who has had a miscarriage before, and certainly if it is the first pregnancy with bleeding, you don't always think about investigating and treating. But hopefully what we end up doing today is with these two lectures, you're able to get a nice, well-rounded view of how to manage miscarriage in your practice. Okay. So having a miscarriage is a very devastating experience for couples. And they would say that although it is a very early pregnancy and some people don't think about it, the impact can be as severe as having a stillbirth. And lots of women have anxiety, depression, suicidal ideas. There are even marriages that break when something like this happens. For doctors like us, it's very frustrating because until now, there has been no real evidence to tell us what to do. Very few effective interventions. So what I'm going to do over the next few minutes is try and deconstruct all of this evidence and use whatever useful information we can get to help us manage the heartbroken couple sitting in front of us. Now, actually, miscarriage is very common. Preclinical loss is very high. We don't even know how high because most women don't realize they are pregnant when they have a delayed, what they think is their period. But clinical loss after 6 weeks is almost up to 20% actually. But if a woman gets to 10 weeks and 16 weeks, you realize that the prevalence is much lower. So you can use this to say that if you see a woman progressing with a healthy, viable pregnancy up to 16 weeks, you can assure her that now her risk of miscarriage is less than 1%. 2 miscarriages, 3 miscarriages, actually very rare. So these are the women obviously you want to help. And with what we know now, there may be something we can use to help them. Now, what's important to realize is there is always a background risk of aneuploid miscarriage. This is where genetically something's wrong with the baby. So no matter what you do, you might not be able to help these women. And if you look at someone who's just had 2 miscarriages, you will see that in the total percentage of miscarriages, about almost 20% is because genetically something's wrong. And it's a very small group where there is something else that is the cause of the miscarriage. But if you look at someone who's had 4 miscarriages in the past, then you see it's almost 50-50, 50% where it's something you can't do anything about, but 50% maybe we can help. And if you look at 6 recurrent miscarriages, the bigger group is women for which maybe something can be done. And this is very important because it makes us think, should we test for karyotype in miscarriage tissue for abnormalities? Now, RCOG says yes, FIGO says yes, ESHO says yes, AR serum says may be useful. In practice, it's a very expensive test. Useful maybe because some couples want an answer, but unlikely really to help us in subsequent management as most of these miscarriages are not recurrent. Now, age is a very important determinant of whether you have a miscarriage or not. And you will see this sort of U-shaped curve where aneuploidy is much higher in very young women and a bit older women. So by the time a woman is about 40, 45, you'll find that her risk of miscarriage is about 50, even 80%, just because the risk of aneuploidy is much higher. And so this is important. But then there are also a lot of other risk factors that are associated with miscarriage. Now, it's important to realize the difference between association and causation. So things like smoking, alcohol, high caffeine intake, working the night shift seem to be positively correlated with having a miscarriage. But you cannot say that because she does night shift work only, every pregnancy that she has is going to be lost. It doesn't work like that. But there are also things you cannot control, like environmental toxin, pesticides. And obviously, if you're overweight or obese, then there's a higher risk of miscarriage no matter what you do. What is important to realize by looking at this list is that some of these lifestyle changes can be changed. You can stop smoking and stop drinking alcohol and stop having caffeine. Whether this will help, we're unsure of. It is good practice advice, but also be very careful not to say this is what caused the miscarriage, because you also don't want to assign blame and make the woman feel guilty. So when to investigate? The different societies say different things. RCOG says 3 or more, ASRM, ESHRE, and PHIGO all say 2 or more, because they understand the importance that people are not going to wait to have 4 or 5 miscarriages because before you as a doctor is going to do something. But why do we want to investigate, right? Well, we want to identify anything underlying for which we can help. Why do we not investigate any earlier than what the society recommends? Because it's not always about what's best for the patient. It's not cost effective. It doesn't make health economic sense. And even if you find a reason, there's not very many interventions that are useful. So things like immunotherapy, beta HCG, surgery for some uterine anomalies, proposed but doesn't really work. So why do it? Why even check? When do we treat? Now that's important. With looking at the previous evidence and, for why people get investigated later, you will realize that there are 2 important determinants for miscarriage in a current pregnancy, and that is any history of previous miscarriage and bleeding in early pregnancy. And what we do know, progesterones given in these 2 conditions can act either as a prevention or as a rescue. Now, Professor Giancarlo has talked about the role of progesterone in great detail, but I just want to summarize that the studies from progesterone started in 1910 on rabbits, where when you remove the corpus luteum and divide them into rabbits whom you give progesterone and don't give progesterone, you find that those with supplementation maintain the pregnancy and those that don't can't. There were some very unethical human studies that looked at the same thing, and it looked like it confirmed the same. Progesterone is needed in pregnancy. This is also how the concept of luteal phase defect was proposed. But there's not really any reliable testing, no reference ranges that we can use to see who is in the group that can benefit from progesterone and those that might not. So all of these studies before shows benefit, but no significant effect on live birth rates. And that's what's important. That's what we want, right? Now, the previous evidence for progesterone before the 2 largest trials, PRISM and were talked about, if you look at the numbers, you find that it's all less than 150. They use different definition for recurrence. They use different gestations of giving progesterone, different types of progesterone. So all of this does not show any significant benefit, but not only because there are so many confounding factors, but also because you cannot remove the background aneuploid cause of miscarriage. Because in every group, there is going to be those that you cannot help no matter what you do. So even when the 2 largest trials were added into this, you find that there's a trend towards benefit, but still not significant because of that group, that no matter what you do, nothing will happen. So in order for us to try and get evidence about helping the group that we are seeing that are genetically normal babies, we have to look at centers that specialize in looking at miscarriage, which is the Tommy Center. Because this is where women get referred when all other causes have been excluded. Because you have to realize that one size does not fit all. It may work for you for a free t-shirt, But for progesterone, you cannot give progesterone to someone who's got an aneuploid fetus and expect it to work. You cannot give progesterone to someone who's got uncontrolled thyroid function, uncontrolled diabetes, and expect it to work. You have to help the group who has a progesterone deficiency. That's what the message is. So the PROMISE and the PRISM trials were the two largest trials conducted in those centers where women are sent when all the other causes have been excluded. So when you don't know what caused it, it is probably a progesterone deficiency. In the PROMISE trial, it's about recurrent miscarriage. So you see the numbers are smaller, but it's still about almost 800 in the different groups. PRISM obviously is looking at threatened miscarriage, bleeding and pregnancy. So here there were more than 4,000 women in both the groups. So comparing progesterone and placebo. Now, Professor Giancarlo has already talked about the other trial. So I'm going to focus on PRISM because this is where we're talking about threatened bleeding in pregnancy. Now, if you look at the difference between progesterone and placebo, although it doesn't seem that there's a significant improvement, you will see that the live birth is 3% higher with progesterone. And so this actually accounts for 54 extra babies in the progesterone group. Still not statistically significant. But if you now look at the different subgroups of women in this trial with bleeding in pregnancy and look at those who had previous miscarriages, you see that if there are more miscarriages before with bleeding, then it reaches statistical significance. And why is it so? Because you've excluded the aneuploid pregnancies. So here, if there is any number of previous miscarriage with bleeding in pregnancy, then there is a statistical significance in reduction of miscarriage. What about the type of progesterone? Does it matter? What was used in the two largest trials is the vaginal micronized progesterone that is most closely resembling the progesterone that the body makes. So because of this is what we propose that you use. Dihydrogesterone, hydroxyprogesterone, caproate, oral micronized progesterone. You cannot make these same conclusions, even though it is supposedly the same hormone, because it has not been proven to be effective, and there are no conclusions about whether it is really safe. Now, this was a meta-analysis looking at all the different types of progesterone used in history. So 7 RCTs with more than 5,000 women were looked at, and they found that in both threatened and recurrent miscarriage, the overall evidence is that progesterone does work and the type of progesterone doesn't make a difference. But what I need you to understand is that the largest number in this meta-analysis was with vaginal micronized progesterone. And so that's the recommendation that we're coming from today. What does it mean for us in practice? That's what's important, right? Do we only treat women when she's had more than 4 miscarriages because that's what the evidence is saying? Absolutely not. We treat women when we see them. What we do have to explain is that if she's had no previous miscarriage but bleeding in a current pregnancy, you have to say that there is a chance that this could be an abnormal pregnancy. And we might not be able to help or change the outcome if that's the case. But if there is any other reason for why you might have a miscarriage, progesterone works. But more important, progesterone is safe. So if you can do something and you know it doesn't cause any harm, and you've explained that perhaps we cannot change what nature has intended in terms of an abnormal fetus, then they're more likely to accept it. When do we screen for other causes? Only when clinically indicated. So we don't just look at bleeding in pregnancy as one symptom. We obviously always make an assessment when we see the patient in front of us. And what are the other causes of euploid miscarriage? There are so many different things. Single gene defects, hormonal specifically diabetes and thyroid, but it has to be uncontrolled hypothyroidism and diabetes, not just any type of diabetes. You might screen for antiphospholipid syndrome, But unfortunately, you can't screen for them at the first start. You have to have a history of at least one normal miscarriage after 10 weeks, 3 or more first trimester, or a history of preterm birth or preeclampsia less than 34 weeks, because that then suggests to you there is thrombosis in the placenta, and perhaps that might be the cause of miscarriage. So you definitely won't screen for antiphospholipid on the first pregnancy. Thrombophilias, uterine anomalies, leiomyomas, immunologic phenomena, infections, toxic exposure, psychological stress. Very, very long list. The evidence for all of these other causes, like I said, only uncontrolled diabetes and thyroid dysfunction. What about surgical correction? You do a lot of scans, you see something abnormal. We know that in the general population, the prevalence of uterine anomalies is only 4%. But in those who have had recurrent miscarriages, it's 13%. So there is something that the uterine anomaly does, right? But what can we do even if we know that this is the cause? It is most plausible if the losses are euploid after 10 weeks and they're morphologically normal fetuses. Types of treatments, only if it's septate. For any other kind, bicornuate, arcuate, it's not recommended at all because it now it threatens the integrity of the uterus that you're leaving behind. RCOG says no, RCT is not conducted. ASRM says maybe. Escher says we need clinical trials. Figo says try for septate, but not for anything else. Antiphospholipid syndrome. Now this is just the one meta-analysis that looked at treating antiphospholipid syndrome. The conclusion is the same. If you give heparin plus aspirin, it seems to work significantly by reducing recurrent miscarriage. Prednisolone and aspirin, very modest, but it increases the risk of prematurity. So we know what the treatment of choice is. So I'm going to end with the same tweet that the RCOG put out last year, where it very powerfully suggested that giving progesterone to women with early pregnancy, bleeding, and a history of miscarriage could lead to 8,450 more babies being born each year. And this has been so widespread that my patients have seen this and have come to ask me if I can give them progesterone. So in summary, the take-home message today is management of women with a previous miscarriage starts from the first visit. Reassurance is very important. Identification of risk factors, lifestyle modification if applicable. Vaginal micronized progesterone is safe, and it appears to be very useful in prolonging pregnancy in those with either threatened and/or recurrent miscarriages. You will only screen for other causes if there are either history or examination that makes you suspect it, and do not underestimate the effect of tender loving care. Thank you very much.
Xin cảm ơn Phó Giáo sư Shilpa Nambiar.
Many thanks to the second speaker. We have about 20 minutes for Q&A. The floor is open. We are waiting for the questions from the participants. There is some microphone in the auditorium. You can write down the questions on paper or you can speak to the microphone. I would really like to ask one question first for both of the speakers. Currently, many doctors use progesterone at the same time, orally, vaginally, and intramuscularly at the same time. So should we combine different kinds of routes of progesterone administration like that, or just one way?
No, I think that is it's not a good medical attitude to combine everything, thinking that it will be more effective. It is not. If we give the appropriate dosage by vaginal route, there is no need to integrate with oral or other route, or even to integrate with the progestogens. There is no demonstration that they are synergistic at all. So you put only patient at risk to have more drugs and sincerely no good effect. What you can do is to choose for the patient the best way of administration. According to, the fact the patient is anxious, you can go for oral route because anxiety go down by oral route. But it should be always micronized progesterone, not other drugs, because they don't have the same effect. As far as we have in Europe, intramuscular route is not popular. Compliance is very low. Patients don't like to have one injection every other day of progesterone, very painful. The 70 to 80% we know worldwide of the IVF center use vaginal progesterone. So I think there should be a reason, because this means that patients are much more easy to take this. I don't know if Dr. Shilpa want to comment as well.
Well, I know that there's in some Asian countries a reluctance to administer vaginal progesterone, especially if there's bleeding. But what we have to explain is that the reason it is given vaginally is because you want it to be absorbed and have the first pass effect where it is needed, which is the cervix and the uterus. If you give it orally, there's going to be some reduction in bioavailability after gut absorption, and that's variable. So if you explain to a woman that the best way to deliver progesterone where she needs it is vaginally, most women, at least in my practice, have been quite happy to do it.
If I can add something, because this is another very important problem that Dr. Shilpa raised. So in treating the abortion with the bleeding, do we give a vaginal or not? In Italy, the most we give at the beginning oral, high dosage for a couple of days, because in a couple of days, the bleeding is almost stopped by progesterone. Then we continue with the vaginal route, and we explain this to the women. So maximum is if the bleeding is particularly heavy, you can give by oral route, but you have to add 200 milligrams more usually. So 1 gram. Okay.
Thank you. Thank you. Xin mời quý vị đại biểu. Dạ, xin mời thầy Tiến ạ.
Vâng, tôi có một câu hỏi là tại vì anh em thực hành lâm sàng thì cũng rất là nhiều. Có thể câu hỏi này
I have one question. These questions go to the two speakers, Professor Dirangio and Professor Shilpa. In clinical practice, to maintain pregnancy, we know that micronized progesterone is quite good, like utrogestan. Vaginally, the maximum dose 800, 400 or 600 per day. But we know that estrogen is also important. With the appropriate dose, both of them would cooperate and become synergistic. However, if there is an imbalance ratio between estrogen and progesterone, they can become antagonistic. In IVF for breast embryo transfer, at that time, the plasma or blood estrogen level is very high. At the oocyte retrieval, estrogen level is between 3,000 up to 5,000 or 6,000 microgram per milliliter. But for natural cycle, the concentration is just about 300, 400 or 500 per mil. So the dose of progesterone for fresh embryo transfer and natural cycle, are they different or just the same dose? Because I see that many people use the same dose of progesterone. What have we got to say?
First, I would say there is no need of giving estradiol when we want to support the luteal phase or prevent abortion. So eventually, the use of estrogen is in preparation of endometrium when we have a frozen cycle transfer. But in the other, there is no need to support with the estrogens. For progesterone, the evidence is that we needed to give at least 600 milligrams a day in IVF cycle. But this is to support the luteal phase. We have not to confound with the prevention of abortion, because this is the second matter. We need eventually a little bit more, because the evidence is now 800 milligrams a day. Okay, so this is what I think, and this is the same either in IVF cycle, either in natural cycle. We have to give it the same amount of progesterone, because the effect is mainly to, let's say, immunomodulate the immune system of the mother and to favor implantation and favor the bad placental formation. And you need a very high dosage of progesterone in this case, not just, 200 milligrams like we use later for prevention of preterm birth. That effect is different.
Xin mời quý vị đại biểu ạ.
We are expecting for other questions.
Cũng xin hỏi thêm hai giáo sư là
One question to the two speakers.
thường hay hỏi là chúng ta chỉ khuyến cáo sử dụng progesterone ở trong thai kỳ.
We recommend to use progesterone during pregnancy. Some doctors, they combine with estrogen in prevention of recurrent miscarriage or threatened miscarriage. Is there any recommendation to combine estrogen and progesterone for recurrent miscarriage and threatened miscarriage?
Nowadays, we don't have any evidence that they are useful, not either synergistic. I just mentioned at the beginning a little about that. We don't add any estrogens for the prevention of abortion.
Ở đây chúng tôi có nhận được một câu hỏi. Yes, please. Ở đây chúng tôi có nhận được một câu hỏi của bác sĩ Nguyễn Vinh Điền. Bệnh nhân có tiền sử sảy thai. Vậy lần mang thai này có nên đặt
This patient has a history of miscarriage. So should I start progesterone right at the beginning for this current pregnancy to prevent miscarriage? Repeating the question, previous history of miscarriage. So for this current pregnancy, should I start progesterone right at the beginning to prevent miscarriage?
I would like to suggest first if we can identify one reason for recurrent miscarriage. For instance, the patient may be diabetic, so have thyroid disorders, or so on. So, because you need a combination eventually of therapy. And then, of course, we should start progesterone as soon as possible. If the patient has a regular cycle and she knows when to have intercourse for pregnancy, I would start at 16 days from the beginning of a menstrual cycle, already progesterone, so the luteal phase. If it's very, inconsistent with the cycle, then it's better to wait the test positive and start progesterone at that time. This is the recommendation that are given by the most. But before try to work up a little bit and to understand why this patient has recurrent abortion or the couple.
Có một câu hỏi tiếp theo là trong trường hợp
The next questions. In case of antiphospholipid syndrome that has not been confirmed, should we administer low dose aspirin and low molecular weight heparin for prevention of recurrent miscarriage?
I don't understand what you mean for antiphospholipid syndrome, which is not confirmed. Because if you find antiphospholipid, they can disappear sometime, but the patient should be classified as antiphospholipid syndrome. So in any case, you have to give aspirin and low molecular weight heparin. If you did the diagnosis once and then you don't confirm in 1 year, you have always to be very skeptical and eventually make more exam eventually and look also to the other thrombophilias. But usually when a patient is classified as antiphospholipid, can be according to the therapy. Sometimes they do corticosteroid therapy and so on. The anticorpus may be, the antibodies may be so low not to be detected. But the patient is still classified as the antiphospholipid syndrome patient.
Thank you. Câu hỏi tiếp theo là bệnh nhân dọa
The
sĩ.
next questions. Threatened miscarriage, receiving utrogestan 800 mg per day. Week 10, stop bleeding. Should I continue progesterone until week 16?
Yeah, no, the minimum period is up to 12 weeks. So even the stop bleeding is after 2 days, you should continue up to 12 weeks to have an effect on miscarriage. However, as I said, the patient with a particularly heavy bleeding is a major risk factor of preterm birth. So usually it's better to continue progesterone, and we use the same dosage until 18 weeks, 800 milligrams, and from 18 weeks to 36, we use 200 milligrams more. So 1 capsule per night. This is what we do now, because the risk of preterm birth in a patient with a treated abortion, heavy bleeding, is 3 times higher than the normal population.
Câu hỏi tiếp theo là điều trị dọa sảy thai ngoài việc sử dụng
Treatment
progesterone.
of threatened miscarriage besides micronized vaginal progesterone, heparin, and aspirin. Should we use something like tranexamine if patient has abdominal pain and vaginal bleeding? Tranexamine if there is abdominal pain and vaginal bleeding?
Absolutely not. Tranexamic acid is used, for postpartum hemorrhage, or, in women, pregnancy is a prothrombotic state. You're not trying to stop the bleeding where the bleeding has already started. You're trying to make the uterus quiet. So that's why progesterone works. And in fact, even if the bleeding has stopped, you continue the progesterone, as Prof. Giancarlo has said. But but it is only progesterone that helps when it is a progesterone issue with the pregnancy. I wouldn't add on heparin or aspirin or prednisolone if there hasn't been a confirmed antiphospholipid syndrome or a thrombophilia.
How about the antispasmodic agent? We need to use on it.
No,
Okay.
because it doesn't work.
Xin mời quý vị đại biểu có đặt câu hỏi gì thêm không ạ? Ở đây thì chắc tôi cũng xin phép tóm tắt lại cái trả lời của mấy câu hỏi vừa rồi.
I would like to summarize some of the ideas, because Regarding the questions of previous miscarriage, should we prevent miscarriage at this current pregnancy? Using progesterone is still beneficial, like in a clinical trial PRISM. People with previous miscarriage, especially this time, there is a threatened miscarriage, progesterone is beneficial. People with 2 times of miscarriage, we should use progesterone. Just 1 time of miscarriage together with vaginal bleeding, use progesterone because it is beneficial. Regarding the dose, 800 mg per day until week 10. Should we continue on to week 16? It is advisable to use until week 16. Do not just stop when the bleeding stops. So if there is a threatened miscarriage during the first 12 weeks of pregnancy, we use it until week 16. That is a recommendation from NICE. Do not stop when the bleeding stops. And if there is history of recurrent pregnancy loss, use it until week 20. And if it is a prevention of preterm birth, until week 34. For anti-phospholipid syndrome, we do not have prophylaxis or prevention. We have to confirm the presence of antibodies, and at that time we would use heparin and aspirin. We don't use it if we don't have a confirmed diagnosis. Regarding antispasmodic, previously, sometimes we would use like spasmaberine or no spa. It doesn't have any mechanisms on the uterus. It just relieves the spasm on the GI tract. If we use it, it would increase the side effect of constipation. So I think that antispasmodic just provides some psychological effect or placebo effect only. Regarding anticoagulant, regarding tranexamic, tranexamine is only indicated for people with the heavy menstrual bleeding or post-delivery bleeding. The purpose is not to stop bleeding, but to maintain pregnancy. So no tranexamine, no tranexamic acid is used in pregnancy. Any other question from the floor? Previously, for people with IVF, with the very high estrogen, estradiol in their plasma, should we have different level of progesterone for those with just 1 follicle? Do we use the same dose of progesterone for people with 1 follicle or several follicles? The recommended dose is just 600 to 800 milligrams. Any other questions from the floor? Should you have no further questions, let's stop here, the satellite symposium, and let's continue the program with the organizers. Thank you. Many thanks for the summarizing from Dr. Lê Quang Thanh, the satellite symposium, program 2B, stopping here. If you need presentation material via email, would you please scan the QR code on the screen to receive it. I would like to express our sincere gratitude to all the speakers and panelists and people who have taken time out of your hectic schedule to be here. Once again, on behalf of the organizers, Besins Healthcare and THÏO Hospital, would like to wish you good health and hopefully we can work together and see you soon. Thank you.
Quý đại biểu vui lòng di chuyển xuống tầng trệt để chúng ta chuẩn bị tiệc trưa và không giữ chỗ. Quý đại biểu tự bảo quản tư trang. Xin cảm ơn.